Thank you, Honourable Speaker. Another cold morning, another winded cough, another bloody tissue, another early lift to the clinic, another crowded waiting room, another lost patient file, another vital check, another tick on the clinic card, another month's supply of medicine if there is any, another lift home, until next month, another visit. This is the reality of many TB and chronic patients in our province of North West. Yes, there are challenges. Yes, there is room for growth. But only by acknowledging these challenges can we take healthcare forward in North West. As we commemorate TB Month and anticipate World TB Day on the 24th of March, we reflect on our progress in fighting TB in North West, where we have fallen short and where we must improve. Now, from the start, we must understand TB and HIV are inseparable from one another. HIV weakens the immune system, making individuals highly susceptible to TB. TB is painful. TB is highly communicable, and it affects largely HIV patients and the elderly. It does not discriminate, Honourable Olifant. Universal suffrage becomes us all. If we hope to control TB in our province, we must prioritise managing HIV. The District Health Programme grant in the Department of Health's budget is intended to develop and implement effective responses to both HIV and TB. Yet, this portion of the budget faces the greatest strain it has seen in 20 years. If the department does not act decisively, 2025 will look far too much like 2004, when we first launched our HIV treatment program. Over the past 20 years, partnerships have brought foreign funding and NGO support to relieve pressure on our healthcare system. Now in 2025, we face the withdrawal of US funding through PEPFAR. Do not let politicians downplay this. They may argue that PEPFAR only contributed 17% to our national HIV funding, but this figure ignores completely the expertise and infrastructure that will be lost. With PEPFAR funding gone, donor-funded health facilities, clinics and NGOs have shut down or reduced operations. Government clinics have lost social workers, clinical associates, nurses and HIV counsellors. The exact staffing impact in the Northwest remains unclear, but it will be significant. I suspect no formal report has come from the office of Honourable Lehare because he himself fears the truth. Take lay counsellors as an example. The US funded 1,931 of them in South Africa. In Northwest, we have 1,175 such lay counsellors. Now, these professionals, what they do in our facilities, they test people for HIV. They support those who test positive. They follow up on patients who lapse on ARV treatment. Now, Honourable Lehare, how many lay counsellors will be lost? And what is your plan to address this gap? PEPFAR also funded nearly half of all data capturers in South Africa, 2,669 in total. These individuals are critical for record keeping and managing patient records. Without them, the department will be unable to track the HIV crisis accurately. These individuals were employed by NGOs funded with PEPFAR funds, meaning on their salary slip it might not say PEPFAR, but that's where the funding came from. To prevent massive disruptions to HIV programs, the North West Department of Health must take action to directly fund the NGOs that provided these essential services. If losing PEPFAR funding wasn't enough, a major TB research program worth up to $200 million has been cut. Smart for TB, a project supporting critical TB trials, has been terminated. It worked with local partners to improve TB testing, explore shorter treatment regimens, and enhance vaccine preparedness. One of its projects, ready to launch before the funds were cut, aimed to improve TB contact tracing, a crucial component in controlling this very disease. Now, Professor Francois Venter, a leading HIV researcher at Wits University, has warned, and I quote, "South Africa faces its worst health crisis in 20 years, worse than COVID. One that will overshadow diabetes as a major killer while pouring petrol on a dwindling TB fire. But it is preventable if our government steps up urgently. Now, US funding supported HIV care through a competitive, focused, and rigorously monitored program in 4 key areas. That's active case finding, tracing patients lost to care, vulnerable population programs reaching communities such as sex workers, individual LGBTQ plus individuals, people who use drugs and victims of gender-based violence. And fourthly, it also looked at health system support, which dealt with the managing of medicine supply chains, laboratories, and information systems. Now, what happens now? The first sign of disaster will be a drop in new HIV treatment initiations. Then we will see an increase in TB hospitalizations, exacerbated by untreated AIDS. By year end, patients who have fallen off ARV treatment will have weakened immune systems, making them even more vulnerable to contract TB. The department will struggle to intervene at all because it will lack the data to recognize the crisis. Because, as already mentioned, among the staff lost to the system are the very data capturers who need to track this information. Honorable Ehare, you are entering a storm and you don't even know it. An expected reply from yourself or fellow ruling party members would be to say, statements were made by myself to win quick political points. Well, this is a standard reply from the ruling party and I anticipate this. But any such statement in this House today, dismissing hard facts as attempts at quick political wins, was written in your comfy chair at home yesterday already. It is a cheap and poor attempt at a get-out-of-jail-free card. The residents of North West deserve strong leadership amidst the brewing storm. Honourable Speaker, and I hope Honourable Ehare is listening, a sensible emergency plan must include emergency funding for existing programs, a phased plan to retain lost positions and make them sustainable over 2 years, holding the department accountable for HIV treatment metrics, integrating patient data across laboratory, pharmacy and radiology systems, recognizing that some key functions and clinics may need to operate outside of the Department of Health. Another cold morning, another winded cough, another bloody tissue, another early lift to the clinic, another crowded waiting room, another lost patient file, another vital check, another tick on the clinic card, another month's supply of medicine if there's any, another lift home until the next election.